My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Center. I'm also the Associate Chair for Multidisciplinary Oncology in the Department of Surgery, and I am the Director of the BPREP program. BPREP is our high-risk program for women who are concerned about their risk of developing breast cancer. Over the last decade, there has been a lot of great change in breast cancer surgery. And the common theme among these changes has been a less is more approach. We are now able to identify patients who can avoid some of the historical or standard surgical procedures, such as axillary lymph node dissection. Axillary lymph node dissection is a great point of interest for us because this is the procedure that is associated with risks of lymphedema or arm swelling after surgery. So in the late 90s, we learned about a technique called sentinel lymph node mapping and biopsy, which allowed us to identify the first lymph nodes that drained the breast. We learned that if we removed just these lymph nodes, it's usually 2 or 3 lymph nodes, and we could examine them for the presence of cancer cells. If there were no cancer cells in the sentinel lymph nodes, we did not have to go on to perform completion axillary node dissection. And this was a significant advance for our patients because most breast cancer patients do not have cancer in their lymph nodes, and therefore we no longer needed to remove all of the lymph nodes to prove that they were negative. This concept has now been expanded to women with cancer in what we say a limited number of lymph nodes. So now we go to the operating room, we perform a sentinel lymph node biopsy, and if women have cancer in just 1 or 2 of their sentinel lymph nodes, we also now know that it's safe to omit completion axillary node dissection in that population. We've had several large randomized trials now demonstrate for us that women with a limited burden of disease in their sentinel nodes, defined as 1 or 2 nodes, do not actually benefit from completion axillary node dissection when compared to either observation alone or compared to radiation therapy delivered to the underarm area. The women do equally well and do not come back with cancer under their arm. So this, again, has allowed us to omit lymph node dissection in a now much larger population of women, those with cancer cells found in only 1 or 2 sentinel nodes. More recently, we've seen an increased use in chemotherapy before surgery for certain breast cancer patients. We consider chemotherapy before breast cancer surgery in women who come in with clinically obvious lymph node disease. So if we know that a patient has breast cancer in her lymph nodes when we meet her, when we evaluate her, if we can feel an enlarged lymph node, we do a needle biopsy of that lymph node, and if we demonstrate that the cancer is there, we're considering ways to potentially eradicate that cancer before surgery with our medical treatments. We do this quite commonly in our patients who present with what we call HER2 positive breast cancer and those that present with what we call triple negative breast cancer. We have several clinical trials now that have demonstrated for us that women with those particular molecular subtypes of breast cancer have a very good response to preoperative chemotherapy and preoperative anti-HER2 therapy for that HER2 positive group. So if a patient comes in with cancer in her lymph nodes, and she has a subtype of breast cancer that we know is likely to respond to preoperative therapy, we'll use that therapy in the preoperative setting in the hopes of eradicating those cancer cells in the lymph nodes under the arm. We then go to surgery after preoperative treatment. We're able to perform a sentinel lymph node biopsy. And if our pathologist tells us that the cancer cells have in fact been eradicated by the preoperative therapy, we are now able to omit axillary lymph node dissection in that population of women as well. This has been, again, a significant advance for our breast cancer patients, and it's really only become popularized in the last 5 or 6 years. There certainly are very many considerations that we have to take in patient selection for this approach. And intraoperatively, as surgeons, we have to be sure that our sentinel lymph node biopsy techniques are accurate and sensitive. We do not want to leave cancer cells behind if in fact they are there. So we focus a lot on what we call our false negative rate of the sentinel node procedure. We certainly don't want our pathologists to tell us that the sentinel node is negative, but leaving a significant amount of breast cancer behind under the arm. So there have been a lot of attention on surgical technique in this setting to ensure that omitting lymph node dissection in this population is safe. We have some follow-up data, some outcome data suggesting that women who are managed in this managed with this approach do very well. They do not come back with cancer under their arm. However, because it is still a relatively new approach, we again need to make sure that we are careful in our patient selection. We need to make sure that we are careful in our intraoperative technique, and we need to make sure that we are following these patients appropriately to identify whether they have any evidence of regional recurrence in the lymph node area. So the management of the axilla is one of the areas where the less is more approach has really gained a lot of traction over the last decade. We are able to omit lymph node dissection in a substantial number of our breast cancer patients, therefore minimizing the morbidity of their treatments. And we are also seeing this less is more approach extend to other aspects of breast cancer treatment. We're seeing our medical oncologists recommend much less chemotherapy than they used to, again, based on the biology of the breast cancer, the molecular subtype of the breast cancer. And we're seeing our radiation oncology colleagues also try to identify women who can omit radiation therapy safely without increased risk of local recurrence. So thanks to our improved understanding of the biology of breast cancer, all of our multidisciplinary team members have really been able to work together to identify places where we can dial back and take a less is more approach.